Okay, so let me go through this. This is usually a part of our course. I'm going to go through it a little bit faster than usual because I can't keep you here all night. But Alistair, who's our cataract department head, usually gives this talk. So I'm going to give you some scenarios of the interaction between PRESBYOND and lens surgery. So case one is a patient who was 52, was a telecoms engineer, everything was fine, refractive history, unremarkable, wanted better distance and reading, but also was noticing a bit of glare. And it turns out that he actually had cataract when he presented to us. So his best corrected vision was 20/30 in each eye, and he was slightly myopic. Now, remember, he's 52, right? His topographies were normal. There was a bit of inferior steepening, but with our epithelial mapping, we obviously excluded that from being keratoconus. But he did have these spokes, and this is real cataract. There's no point in attacking the cornea at this point. He needed cataract surgery. So what did he have? He had an OSI that was raised, and so the question here, stop photographic thing, what would people offer him? What would people offer him? And most surgeons in the world do lens surgery with monofocal, with monovision. Now, he had this done, but he came back 4 years later and said, look, I want more spectacle independence than I currently have. And his status at the time was that he was essentially plano and minus 0.5, and he wanted more reading, even though his reading was an 8 already. Notice that his OSI was neatly transparent, and so we fixed that problem. His pentacams looked the same, and he had beautifully executed cataract surgery. Thank you, Alistair, you're very good at this. And he had monofocal IOLs, so that means that he didn't have a whole bunch of other issues that we had to deal with. So we do PRESBYOND on him, and we do our standard targets. We pop in the spherical aberration that we measure from the aberrometer, and this is his post-op day 1 cornea look. It looks fantastic, and now he's seeing 20/12 and N4, yeah, J2. So he's a real happy camper at 3 months, and so that's Bob your uncle. So as you can see, we've converted a pseudo-phakic patient into a PRESBYOND patient. Daniel talked about the fact that he basically can go to all of his previous cataract surgeons and bring them back for a PRESBYOND upgrade. And the binocular intermediate, by the way, is N4 as well, which you're not expected to have that depth of field with just monovision as such. Okay, this is his topography. So from his perspective, he sees everything at distance, intermediate. He can drive at night. He wears +1s when he looks at those. You've seen these people work on these things in the street, right? So he has to look at all those little numbers. He puts a little extra in. Here's the second case. Now, this is what we call, this is what I've called, people talk about premium cataract surgery. And so I call this premium cataract surgery, no really. So premium cataract surgery, comma, no really. And that's because what we're doing is targeting the cataract surgery to about +2 post-op. Now, why do we do that? Well, here's a 68-year-old jazz musician who was healthy, everything was fine, nothing remarkable in his history, but he noticed a deterioration in his vision over the last year, having a bit of trouble reading music while at the piano, and wanted a solution. So he presented, I examined him, whoa. He was -7 and 20/50 cataracts in both eyes, and I said, look, we could do laser, but it can only do the best that you can get with glasses, and you need cataract surgery. And he said, no, I don't want cataract surgery. No, you need cataract surgery. He said, no, I don't want it. My glasses are fine. If you could do what my glasses are, I'd be happy. I said, no, you don't understand. You are not legal to drive even with glasses. He was like, what? I'm driving now. Anyway, so I sent him back to the States, and he lives in Florida, and Florida has some of the most high-volume cataract surgeons in the Western world, and I had to instruct his ophthalmologist on how to select the IOL and target things for me. And so this is how he presented with these gorgeous nuclei, very well delineated there. And, obviously, we targeted this procedure. I explained to this patient all of the process that we're going to take him through, that he's going to need glasses after the cataract surgery for distance and near, but that once he comes to me, I'll make him as independent as possible. He came back a year later, ready to go. He had a little bit of amblyopia in his right eye, it turns out, and so here were the treatments that we performed. His manifest refraction was about +2, which is what I'd asked his surgeon to deliver. His topographies looked fine. His surgeon sent him back to me like this. Okay, not too bad. And we targeted plano and -1.625. And this was his post-op day 1 refractions. You could see that he was plano and about -1.375. And here we are. He was seeing 20/20 and N4, 20/25 actually, without correction. His intermediate vision, though, was N4 as well. Okay, and that's important for a pianist. His corneas look great. You can see the beautiful Visumax flaps here, and his topographies looked fantastic. So this is a huge amount of perfectly centered spherical aberration on his visual axis, and this patient, was Chick Corea. And any of you out there who are jazz fans will know that if you operated on Chick Corea, you basically operated on Jesus Christ. If you're like in the Catholic Church, I mean, I basically did surgery on God, and I had obviously front seat tickets to all the concerts. I want to mention that I've operated on 2 of the other band members, and he's on his way. But he says his eyes are working perfectly, and he doesn't use glasses for the audience, for the music stand on a piano, for reading in bed, and for driving at night. So let's talk about a situation which is, I think, the threshold situation where you do see some lens changes, but we might still choose to do PRESBYOND. So 54-year-old, okay, and generally good health, everything, would like to be glasses free. TV can be a little bit glary. Now, she had 20/20 and 20/16 vision, and she had myopicized in this eye slightly, you see. So we know that this is not a good situation for stability, but she's a myope, and her axial length and her vitreous is still attached. This is what her night vision simulator showed with those lenses in her that she had. Her topographies were clear, everything was go. So you can see there's a little bit more yellow on the right lens, but not a lot. And I know a lot of people say, oh, it's a little bit of cataract, we got to take that out, prevent it from getting worse. Why do 2 surgeries when 1 will do? Well, in her case, we did extensive counseling, and we said, look, you are developing nuclear sclerosis, you are going to myopicize, but the transparency of your lens is still excellent. And we really think that because your accommodative range is still quite large, we think that you'll do very well with PRESBYOND until that lens develops. And the older you can be before we take that lens out, the more likely your vitreous will become detached, and the safer the cataract surgery will be for you. So it might be a year, it might be 5 years, it might be 7 years, we don't know. But count on the fact that you're going to be back for lens surgery at some point in the future, except you'll only have that lens surgery when it's necessary. And this is the way we discussed it. And, we chose to do blended vision with special counseling. Now, I under-targeted that eye because I thought that she would develop a bit of myopization over time. So I bought her a little bit of time. She could be -175 and still be happy. And she ended up, we did all the testing, and she ended up at 3 months, super happy, 2016 and 4. And here we are. This is what her lenses look like. Now, obviously, when you just look at the lens, it looks like you've got to do a cataract surgery. But using ocular scatter measurements tells you a lot about where the patient is in terms of visually significant cataract. So, we've got a case like that where a couple of years ago she came back. So cataract after LBV and the IOL chosen specially. So we have a 65-year-old female who presented with a relatively high hyperopia, and she had normal contrast, above age normal. Her topographies looked great. Her Ks were within reason. Her corneal thicknesses were sufficient. And yes, she had a little bit of lens changes you'd expect for a 65-year-old, but we performed blended vision. Now, that means a plus 550 treatment in one eye. And most people say that can't be done. But please read our papers on epithelial monitoring, which totally changes the game on how to do hyperopic LASIK. Here is her data over a period of 10 years. And you can see that we actually had remarkable stability over that 10-year period. And the correction, she basically had a very, very little change over that 10-year period. Just a little bit, all within a diopter. And her vision remained relatively stable. 0.4 diopter change, 0.6 diopter change in the Ks. Now, this is what her corneas looked like 10 years post-op, okay? Right? Not too bad, right? Not too shabby. Okay, good. Now, she comes back and she's seen 20/30, okay? So she's seen 20/30 now and 20/25 with those topographies. Now, are those 20/30 topographies? No, they're not. Are those 20/30 lenses? No, they're not. Why is she 20/30? Because she had fluffy, ugly drusen all over her macula. And this is a prime example of where you can have a clear OCT at the age of 55 or 60, and 10 years later, you've developed macular changes, and now you have a diffractive, light-cutting, contrast-compromising IOL in the visual pathway. So her maculae were 20/30, and so therefore it is a good thing that we didn't do cataract surgery, which might have accelerated her dry macular degeneration into wet. We know that 15% of Westerners are going to develop macular changes. So it doesn't matter if you have the OCT clear in the mid-50s, 1 in 6 of those patients is going to develop macular changes. So, beware that this is not a clear pathway just because the OCT is normal. We know that the incidence of cataract is higher in those that have had phaco. We know that age-related maculopathy is accelerated by cataract surgery, as implied by the Beaver Dam study, where they showed that those that had phaco progressed to AMD, 6% of them in 5 years, whereas those eyes that did not have phaco, only 0.7% progressed to AMD. So you can accelerate AMD by doing cataract surgery. So the last case here is, here a 65-year-old in whom we detected a myopic shift in the right eye with cylinder, and this was, obviously due to lens changes. We did cataract surgery, and she'd already had blended vision, so all the depth of field was already in her cornea, and with a -175 target, she was now seeing N4 20/16 in the other eye that didn't have cataract, and again, restored to happiness. So how do you do these IOL calculations when you've already done PRESBYOND? Well, the answer is it's the same as any LASIK patient. If there's a decentration, you got to take care of that first before you do the cataract surgery. But you can go to all the websites and try all the equations and use the ASARS calculator to look at everything. But our experience is that the Barrett True K, in the case of a well-centered refractive surgical procedure where the spherical aberration is within target range, within therapeutic range, the Barrett Universal is phenomenally accurate. And so going by the principles of the therapeutic and toxic levels of spherical aberration, so we choose IOLs based on that. And so, you've got your ocular wavefront, you've got your higher order aberrations of the whole eye, and then you've got your higher order aberrations on the cornea. And what you're trying to do is to get the corneal aberrations to add up to the lens that you're going to put in, so that the whole eye has the right amount of spherical aberration. So the example here that I'm going to give you is a patient that had had a big treatment, had a 0.71 microns of spherical aberration on the cornea, okay? And I'm going to choose a lens that will help push the spherical aberration into target zone. So I'm going to put the minus 0.12 spherical aberration lens to reduce the plus 0.71 to minus 0.59. And that's going to give us a much better optical depth of field without loss of contrast. Likewise here, for example, a patient who starts with 0.2 on the cornea, we want to perhaps jack that spherical aberration up a little bit. So we use an MA60 AT because we put 0.14 into the cornea and make the whole eye have 0.34. That increases the depth of field, gives us blended vision with IOLs. So Zeiss have, we're talking on a Zeiss platform here. Zeiss have a full range of options for you to have negative spherical aberration, neutral spherical aberration, and positive spherical aberration in order to, customize this lens surgery that will be done after PRESBYOND. And of course, with PRESBYOND and monofocal customized lenses, you're avoiding all of the side effects that Dan Senecal talked to us about, and you're maintaining the ability for full binocularity with full contrast if all you put on is a pair of spectacles. So here, I'm taking through a whirlwind tour of the different kind of options in and out between lens surgery and corneal surgery